Wonderful. Thank you. Welcome, everyone. On behalf of Dr. Chen and I, we're delighted to be here to talk about multiple sclerosis and MOGAD in pediatric patients. So as mentioned, I'm Brenda Banwell. I'm the chair of pediatrics here at Johns Hopkins, and I work with Dr. Chen in the neuroimmune program. Next slide, please. These are disclosures. I have served as an advisor on clinical trials for therapeutic safety and advocacy, as well as outcome in pediatric MS patients. None of this work is related to my role at Johns Hopkins University. Dr. Chen is the site principal investigator of 2 clinical trials listed here and a co-investigator of a third trial trials related to treatment of MOGAD. Next slide. All right, so our goal of this podcast is to present the typical clinical features of pediatric multiple sclerosis and myelin oligodendrocyte glycoprotein antibody-associated disease, much easily referred to as MOGAD. We will talk about how the diagnosis is made for pediatric MS and MOGAD, and we'll illustrate what each of these conditions look like on imaging. Dr. Chen will then take over and discuss the biology of the 2 conditions, and then we'll come back around to management of acute attacks and management for attack prevention. And very importantly, we will then move over to a question and answer period where we can make sure that we address things that you would like us to talk about as well. Next slide. All right, so importantly, we always start with where the patient first presents to us, which most of the time is because they've appeared in the emergency room or in clinic with an acute and emerging series of neurological findings related to inflammatory demyelination in the central nervous system. Illustrated here is a 5-year-old on the top who presented with acute encephalopathy, so impairment of level alertness, severe drowsiness. He had impaired balance or ataxia, diplopia, which means double vision, and had motor weakness in his upper and lower extremities. As the MRI on the side shows, there are multiple areas of bright white signal. And I know not everybody on this call is a physician, so I'm going to make sure I don't overly use this medical jargon, but do interrupt me if I use terms you don't understand in any way. But you can see on this MRI multiple areas of this bright signal, which is very characteristic of what we call acute disseminated encephalomyelitis, or ADEM. The second patient is a 14-year-old girl who came in with what we refer to as Lermite's symptom, which is an electrical shock-like sensation that radiates down the spine and is stimulated by forward neck flexion. This is characteristic of a lesion irritating the spinal cord, particularly the cervical spinal cord. And while that is not specific for demyelination, it's very common in people who have demyelinating lesions in this area. She also had bilateral sensory loss and motor weakness, and there is a small focal lesion in her upper cervical spine. This presentation is referred to as myelitis or transverse myelitis. On the bottom, we have an 8-year-old girl who came in with acute unilateral visual loss of her right eye. She had pain with eye movement. And when we tested her color perception, she had difficulty seeing the color red. It looked brown to her. And on that image, you can see that the right optic nerve is bright and thickened compared to the left. And this is optic neuritis. And finally, the last image is a 14-year-old boy who came in with some numbness and tingling in his left upper extremity. When I examined him, his optic nerves showed that there was some pallor, which means that something had probably inflamed the optic nerve in the past, and his tendon reflexes were very easy to get, and it abnormally increased. So even though his physical finding of sensory loss was very mild, his MRI shows multiple areas of inflammation in the brain, those bright white areas, and this was his first attack of multiple sclerosis. But the number of changes on his brain MRI remind us that multiple sclerosis starts well before the first attack and certainly has been occurring in his brain with enough time to accumulate multiple areas of inflammation. Next slide. Moving to another example. So this is a 15-year-old. She came in also with visual loss, similar to the child I presented on the prior slide, and also had right optic nerve inflammation. But her brain MRI shows multiple areas of bright T2 signal abnormality. You can appreciate on the middle image that some of them look rounded and well-defined, and other areas are hazier and sort of more diffusely abnormal in her white matter, also indicating that this process has been going on for some time. But also importantly, as shown by the blue arrow on this T1 weighted image, she already has areas of focal tissue loss or encephalomalacia that are appearing as dark black, almost the same signal as spinal fluid. And these are permanent black holes or areas of permanent tissue injury that were present even though this was her first clinical attack. So again, making the point that this disease starts well before the patient comes into us with the first set of symptoms. Next. So when we diagnose multiple sclerosis, we think about it right as it is described in the name. So the first part of the name is multiple. So multiple is delineated by dissemination or distribution in multiple areas of the central nervous system. And then also dissemination in time, meaning chronic disease. Ultimately, in most patients, relapsing and then remitting clinical disease course. So attacks and periods where things appear to be stable and then attack again. When we look at the dissemination in space or the distribution of lesions, the typical appearance, and in fact, the topographies that are formally in the diagnostic criteria include in A, periventricular lesions. So you can see the yellow arrows are pointing to everything I say. So these are lesions that are close to the ventricles, which are normal fluid-filled spaces in the brain. Juxtacortical in B, which are lesions that rub up right against the border between the cortex and the white matter. In C, there's an arrow pointing to a bright, slightly enlarged left optic nerve. And in D, there's an infratentorial lesion in the posterior aspect of the brainstem, illustrated with the yellow arrow there. In E, we see a focal lesion in the spinal cord, which also counts toward the infratentorial and spinal cord distribution. And then finally, in F and G, these are special sequences that are now recommended, particularly to help make the diagnosis of multiple sclerosis by illustrating particular appearances that tell us more about the biology of the disease. So in F, the arrow is pointing to a dark rim around the edge of a lesion, and that's a paramagnetic rim lesion, which if we put a microscope there, would show macrophages that are activated, ingesting myelin, and also expressing iron. And then on the bottom in G, we see that many lesions in multiple sclerosis have a vein running right through the center. And later, Dr. Chen is going to show you why when she illustrates some of the pathology. Next slide. And, while we have very clever criteria that have been evolving now over multiple international meetings, and the McDonald criteria that we use for the diagnosis of multiple sclerosis is on the current 2025 version. In reality, we've been trying to catch up to the drawings illustrated here by Charcot more than 150 years ago, which is that the distribution of change in the brain in both children and adults with multiple sclerosis, as highlighted in the areas here on red, involve the brainstem and the pons, and then supratentorially, preferentially involve the periventricular white matter, as you can see here. So these images are a composite of 30 pediatric patients in the pediatric rows, 30 adults, all merged into one image. And where the image is bright is where lesions were present in more people out of the 30. And you can appreciate that it really lights up the periventricular white matter in particular. Next slide. So importantly, and since we're speaking about pediatric multiple sclerosis, we'll stay with the fact that multiple sclerosis in children follows relapses and then remission, so a relapsing remitting disease course. There is a form of multiple sclerosis referred to as primary progressive multiple sclerosis that we're not going to talk about today, because effectively we do not see that in children. But the disease course of multiple sclerosis illustrated here is the preclinical phase where we know new disease. We know that there are lesions forming, but we don't yet know the patient typically. And then you have a first event that brings you to medical attention, and then clinical relapses thereafter. And what we're very much wanting to prevent are those relapses, but also what's called secondary progressive disease activity, which is a stage of the disease where the relapses are pretty infrequent, but increasing disability occurs, potentially related to loss of cerebral reserve, accumulation of disease burden over time, and negative impact on overall neural function, including a negative impact on both neurons and white matter. Next. So to wrap up the diagnostic component of multiple sclerosis, the majority of people present with signs or symptoms, just like I explained a few slides ago. We always make sure that we're not missing something else. So a thorough workup to make sure one is not seeing a patient perhaps with infection, sarcoidosis, neurolupus, other conditions that can mimic multiple sclerosis. We'll talk about MOGAD in a minute. And then we follow the diagnostic algorithm, which indicates that if someone has two or more lesions that hit two or more of the recognized 5 topographical regions, and have either one of those 2 more biologically relevant findings, so the central vein sign or paramagnetic rim lesions, or if they demonstrate dissemination in time, which means they could have a second event, or if you're making the diagnosis at the first event, do they have both enhancing and non-enhancing lesions? And finally, and new to the current criteria, if someone has lesions that hit 4 of the 5 topographies, that's all they need once you've made sure that other diagnoses have been excluded. Sometimes people come in with maybe more than one lesion, but only one of those lesions hits the area identified, those 5 areas that I discussed. In that scenario, you have to have even more evidence, as illustrated in the bottom box, to support that this individual has multiple sclerosis. So you need positive spinal fluid, such as oligoclonal bands or kappa-free light chain, and imaging characteristics, as we've just discussed. Next slide. So what's new in the current criteria? So as a practitioner, if you're making the diagnosis of multiple sclerosis in your clinic, the new version of the criteria have a few important components. 1, lesions of the optic nerve now count as one of the 5 topographical regions, whereas previously it was periventricular, juxtacortical, infratentorial, and spinal cord. So the 5th now is optic nerve. As we illustrated with the central vein sign and paramagnetic rim lesions, those findings on imaging can contribute to confirm the diagnosis of multiple sclerosis. They were not included in the previous criteria. In terms of the spinal fluid analysis, I didn't show a slide on this point, but you can have positive spinal fluid by having the presence in spinal fluid, but not serum, of oligoclonal bands, which are intrathecal synthesized immune globulin. We don't know what it's directed against biologically, but it is is present in about 97% of persons with multiple sclerosis, even though it's not entirely specific. But you could also confirm positive spinal fluid by something called kappa-free light chain analysis, which is relatively less frequently done here in the United States, more often done in Europe, although that may change over time. I'm going to show you a slide on radiographically isolated syndrome next, so I'll leave that for there. And then as in prior criteria, you needed dissemination in time. So when MS criteria were first proposed, now more than 50 years ago, you had to have more than one clinical attack, no matter what your first attack looked like. And of course, at that time, that was prior to MRI. With MRI, we made it easier to make the diagnosis of multiple sclerosis by showing that dissemination in time could be met by having both enhancing and non-enhancing lesions. And now in the 2024 criteria, if you have lesions in 4 of the 5 topographical regions, that alone would be enough, even though you don't have enhancing and non-enhancing lesions. So we've moved further along to facilitate prompt diagnosis. Next slide. So just a quick moment on the situation of what's currently called radiographically or radiologically isolated syndrome, which really isn't a syndrome. It's a situation where somebody has had an MRI, perhaps for migraine or some other reason, and the MRI looks like the one below, with multiple lesions, very typical for multiple sclerosis. In that scenario, it certainly makes sense to consider the diagnosis of multiple sclerosis, even though the person has not yet had an actual clinical attack. So to confirm the diagnosis in that individual, if you have lesions in the typical locations and positive spinal fluid and this positive central vein sign, which indicates that they're not only are there white spots in the brain, but they are biologically very similar to what we would expect in multiple sclerosis, then you can make the diagnosis even at that time. Next slide. So in pediatric patients, we use the same diagnostic criteria that we use for adults. It is the same disease, whether you are 10 or 40. There are some age-related slight differences, but it isn't a different disease in children. And the diagnostic framework is the same for children and adults, with just a couple of caveats. One caveat is if a patient presents with ADEM, which I showed you on that very first slide, where the patient presents with encephalopathy and multiple neurologic findings, and an MRI with very widespread, huge areas of T2 bright signal, that is atypical for multiple sclerosis. In a child with ADEM, please test for MOG antibodies because 50% of those children will be positive. And if they do not have MOGAD, then following closely for an attack that is more typical for multiple sclerosis is important before the diagnosis of multiple sclerosis is conveyed. The advanced imaging biomarkers, the central vein sign and paramagnetic rim lesions, are less well studied in children than adults, and so we're being careful and making sure that those apply equally well to pediatrics. And then, as I just mentioned, testing for MOG antibodies is very important, particularly in children under 12, because the pre-test probability of having MOGAD is almost 50%. And now, Dr. Chen.
All right. So we're going to talk a little bit about the biology of multiple sclerosis. As people may have heard, multiple sclerosis is categorized as an autoimmune disease, but what does that really mean? Our immune systems are typically responsible for protecting our bodies from infection. And in MS, the immune system mistakenly targets the attack towards the central nervous system. So immune cells that are usually in your blood vessels make their way into attacking parts of the brain, the spinal cord, and the optic nerves. And this produces inflammation in those areas that damages cells within the nervous system. So here is pictured a neuron or nerve cell that sends signal along the axons or nerve fiber. There's this myelin, which is a fatty substance that surrounds and insulates the nerve fibers, much like insulation on an electrical wire. And the oligodendrocytes are the cells that produce the myelin. And so when you have this inflammation from these immune cells that penetrate into the central nervous system, it damages the oligodendrocytes and the myelin, which is why the process is generally referred to as demyelination, but also damages the axons underneath so that messages no longer travel efficiently between the brain and the body, leading to people having symptoms. And shown here are just our B cells and T cells, which are specific types of immune cells that are important in MS. But we are actually still working on really understanding how different immune cells and specific targets may play key roles in the development of and progression of MS, and it's still an area of ongoing research in the lab so that we can better understand how this happens and hopefully develop new treatments, not just to halt disease progression, but also to recover lost function. So why did this happen? Why did your family member or someone you know or your patient develop MS? And that's also something that we're still working on understanding better, but we suspect that it's a combination of factors, that environmental factors may trigger MS in a genetically susceptible individual to cause immune dysregulation. And going into a little more of these specific areas, In thinking about environmental exposures, one of the most significant environmental risk factors for MS is exposure to the Epstein-Barr virus, or EBV, the virus that causes mononucleosis, or mono as many people know it as. And although and almost all patients with MS have EBV before the onset of MS, making EBV somewhat of a prerequisite, if you will, for developing MS. Of course, most of us by adulthood have come into contact with EBV at some point and not developed MS. So why some people develop MS after is not completely understood, though it's hypothesized that EBV may mimic proteins from our central nervous system and also transform cells in our immune system that facilitates autoimmunity. And so this is actually just a study where once we exclude the patients who have MOGAD, which a diagnosis that was not or a testing that was not available till much later since the start of this study, we actually found that 96% of MS patients were EBV positive compared to either controls seen here in gray or MOGAD patients. Another environmental exposure or risk is vitamin D. We've known for some time that higher levels of vitamin D were associated with reduced risk for developing MS. As a result, MS is far less common the closer you get to the equator. And higher levels of vitamin D have also been associated with reduced clinical activity in people already diagnosed with MS. So this is a graph where on the y-axis, you have a percent of patients without relapse, and the x-axis is time. And different shades of these lines define different levels of vitamin D. So the darker lines are higher levels and the lighter lines are lower levels. And so lower vitamin D, as you can see, was associated with more relapses over time. So genetic risk also plays a factor. Some of your DNA or your genes can make you more susceptible to getting or developing MS. We see that there's a higher risk of MS in first-degree relatives, so about a 3% chance of getting MS if you have a first-degree relative with MS, compared to the general population, where there's probably about a 0.1 to 0.3 chance of getting MS. Clearly, it's not the only reason why people get MS. We also know that women are more likely to get MS than men, and one of the other strongest genetic associations with MS is found in variants of the human leukocyte antigen, or HLA gene, that's important in immune regulation. And a version of this HLA gene called HLA-DR15 is a commonly linked risk factor for MS. And this kind of alludes to the point that, not surprisingly, all of these factors interact with each other. Those HLA proteins actually work by enabling cells to display antigens, your immune cells, to work in ways to respond to infections. And people with that HLA-DR15 type actually may facilitate EBV infection, can maybe cause stronger immune responses that then become dysregulated, resulting in autoimmunity. So it's probably stacked risk factors over time. So, that said, what happens once someone is diagnosed with MS? And generally, as soon as we find out that someone has MS, we work on starting disease-modifying therapy with the goal of these medications to prevent MS from getting worse by preventing new attacks or further damage. About 5% of all MS patients have childhood onset of the disease, but currently there's only one FDA-approved treatment for MS in children, which is fingolimod. And in contrast, this is actually a non-exhaustive list of approved medications or treatments for MS in adults. We actually somewhat seldomly use fingolimod due to adverse effects and sometimes concerns for compliance because it's a daily oral medication. So we often use other therapies off-label, and consequently, we also participate in international clinical trials, such as this one for ocrelizumab, currently in process, which is a once every 6-month infusion. And hopefully we will have more FDA-approved treatments for pediatric onset MS. And with that, we'll transition into talking about MOGAD, myelin oligodendrocyte, glycoprotein antibody-associated disease, which is another autoimmune disease that has, over the last decade or so, emerged as a distinct clinical and imaging entity. Like with MS, in MOGAD, immune cells will attack the myelin, But unlike in MS, people with MOGAD actually have an antibody that we can measure in their blood against a specific protein that's on the outer layer of this myelin sheath, and that is the MOG protein. And as with MS, but even more so, I think there is a lot more research that's needed into understanding the development and pathophysiology of MOGAD. And with that, I will turn it back over to Dr. Banwell.
Thank you. So just as the situation occurs in multiple sclerosis, the diagnosis of MOGAD rests on a clinical presentation and supportive laboratory and imaging features. And in both conditions, the requirement of exclusion of better diagnoses is always in play. I appreciate that's challenging because sometimes the diagnosis that you're debating between is multiple sclerosis versus MOGAD. So we're going to touch on that as well. But the diagnostic criteria for MOGAD include a core demyelinating event, typically, as listed here, optic neuritis, myelitis, ADEM, a cerebral attack with one or more lesions, a brainstem attack, often with cerebellar deficits, or a phenotype that we're seeing maybe a little more often now that we recognize it, which is a cortical encephalitis, often with seizures. So some children and adults can present with new onset seizures and sometimes fairly subtle MRI findings of cerebral cortical encephalitis, and then very clearly positive MOG antibody titers. So the next step is to actually find antibodies directed against MOG, and this is best done through the use of a cell-based assay. So when you send lab tests, it's very important you know how the assay is being run. So a cell-based assay as compared to an ELISA, which is not robust, whereas a cell-based assay is then provides a titer, or how many dilutions would it take to get rid of the antibody from the sample. A clear positive result, which we define in the paper, but basically in many labs is greater than or equal to 1 in 100. You do need to look at the lab that you're using that will define clear positivity. If you have that plus a typical clinical presentation, you can confirm the diagnosis of MOGAD. If the titer is lower, or if for some reason it was only done in spinal fluid, and I'll take this moment to remind everybody that you look for MOG antibodies in serum. There are labs that will run spinal fluid testing. We really don't yet know fully what spinal or CSF MOG means. Please don't use CSF MOG testing as your way to make this diagnosis. MOG antibodies are much more readily detectable in serum, much more reliably so, and the diagnostic criteria really are meant to be used with serum MOG testing. So this is very important. If the MOG antibody titers are low, or if for some reason you're in a lab that doesn't provide a titer, then we need more supportive evidence. And as listed here, we have supporting features that I'll show you in the next slide on imaging or on physical exam that would support that the type of optic neuritis, myelitis, or cerebral syndrome is typical for MOGAD, and they're listed here. Next slide. And perhaps more easily illustrated here. So the optic nerve lesions in MOGAD tend to be extensive. So they start at the anterior aspect of the optic nerve, even sometimes with papillitis or rarely with retinal hemorrhages, and then tend to extend the long length of the optic nerve. They can be quite swollen. So optic nerve swelling is prominent, and sometimes there's even a perineuritis or inflammation of the optic nerve sheath. The spinal cord lesions tend to be very prominent in the lower cord. They can be anywhere, and they can be longitudinally extensive. So some patients have almost the entire cord inflamed. But in MOGAD, lumbar lesions are more common than you tend to see in multiple sclerosis. And there can be central cord involvement as shown by the H sign illustrated by the figure H. Cerebral presentations are shown on the right part of the panel. And here you see that the lesions in MOGAD tend to be less well defined. In other words, they're hazier, larger than we would typically see in multiple sclerosis. And then in N and O, you can see this cortical cerebral presentation with lesions involving the cortex, sometimes with overlying meningeal enhancement. Next slide. And this just illustrates the different optic nerve characteristics. So we're not going to talk about aquaporin 4 NMOSD in the presentation today, but happy to answer questions if anyone has them later. But the lesions in MOGAD, as we just discussed, tend to be long and extensive in the optic nerve. They can also be bilateral, either at this exact same time or within 30 days to have both eyes involved. Whereas in multiple sclerosis, the lesions tend to be focal. And not infrequently, they don't reach the anterior aspect of the optic nerve. So you may not, at the time of an acute optic neuritis event in multiple sclerosis, you may not see optic disc swelling in that patient. You will see optic nerve atrophy after a significant episode of optic neuritis in any of these conditions, but that's a later effect that takes several months to develop. Next slide. So MOGAD is actually relatively common in pediatric patients. So this was a study we did on our Canadian National Prospective Incidence Study that ran from 2004 until the pandemic. And samples were archived within 24 hours of presentation. And so we went back to these samples and ran them in a high quality research lab and determined the presence of MOG antibodies using a live cell-based assay. And what we found is that in children under the age of 11 in this study, almost half were MOG positive, whereas only 15% of the teenagers had MOG antibodies. But overall, a third of patients did. When we looked at positivity, 77% of the patients that had MOG antibodies were under age 11. So definitely more common in younger patients. Now, MOGAD occurs in teenagers and it occurs in adults as well, but it is particularly more likely at the time that you're evaluating a sort of an incident cohort in younger children. So then we looked at MOG antibodies and whether they persist. And so we had obtained blood samples from this population at baseline, 3, 6, and 12 months. And we ran all of the samples in the same research lab using the same cell-based assay. And I make those points because the titers would otherwise vary if we were using different labs. But here we were using one lab where we looked at these patient samples over time. Some people up to more than 10 years total. And what we found is if you were negative at the beginning, you were negative over time. We really did not see patients become positive later in their history. If you were positive at the beginning, however, 36% stayed positive over years, and this was a median of almost 7 years. 57% though became negative, and 7% went up and down over the course of the study. But that's a really important point. And if you look at the curve here, you can see that the time to become seronegative is about 70% are negative at the 2-year mark. So that means if somebody had an episode of optic neuritis or ADEM or myelitis, and they were MOG positive at that moment, but they weren't tested, and you meet them 2 years later, perhaps when they're having a new attack, the test could be negative, even though they would have been positive if they had been tested early. And that remains a diagnostic problem. We don't yet have international consensus on what to do with someone who looks like they have MOGAD, who no longer tests positive for antibodies, and how do we confirm the diagnosis retrospectively. In children with ADEM in the orange, they become seronegative, the children with ADEM in purple and the non-ADEM is in orange. The children with ADEM in purple become seronegative even faster. And that's interesting because they tend to have the higher titers at the beginning. So they're the ones that are often 1 in 10,000, but they become seronegative even more quickly. Now this graph, every horizontal line is a different child. When they're dark blue, they're MOG positive. When they're light blue, they're MOG negative. And all the little dots are the times that they had their blood measured in the study. And then what we want to point out, if you can click again. Oh, all right, sorry, go back. Sorry, I forgot to finish my comment. So what you can see, if you look partway down, you can see some of the children that are dark blue at the beginning, then they have a period of years where they're light blue, and then they turn dark blue again. Reminding us that sometimes patients can be seropositive, then seronegative, then seropositive again. Some patients can be seropositive for years. Some are only seropositive for a short time. What's not shown on this slide, but I'll just make the point here, the MOG titer at the beginning, whatever their first titer is, does not predict relapses. So please do not put someone on chronic therapy to prevent relapses just based on the MOG titer alone. We do not know yet what predicts relapsing MOGAD compared to what we call monophasic MOGAD, or one attack only. But what we do know is that about 50%, it changes in how long you look, of people with MOGAD actually remain monophasic, or at least children. So they don't need chronic therapy because, as best we can tell so far, they don't experience any more events. Next slide. So this is what I was trying to get at with respect to that. So this is actually a summary of an Australian cohort. And I just want to focus on the right side. This was a cohort of both children and adults, a large cohort that they pulled from their Australian data set, and then led by the Australian team. They also reviewed data from 31 countries, patients from 31 countries. And what you can see on the graph on the right is that the likelihood of someone having only one attack in the first 2 years is about half. And then over time, you can see that people can have a relapse, but it might be more than 5 years after their first event. So this is challenging, because if we had treated everybody from the first event, we would look like we'd prevented a lot of attacks, when in fact, almost a third of the people who eventually have attacks weren't even going to do so until they were more than 5 years out. So this is an ongoing challenge to identify who needs chronic therapy prior to a second event, if we could figure that out. Although I think we all agree that once someone has declared themselves as having relapsing MOGAD, that's when therapy becomes initiated. And that then gets into options for therapy in patients with MOGAD. I'm going to focus on MOGAD, not the aquaporin 4 neuromyelitis optica spectrum disease, which is on the top. And really what we want to do here is target the biology of the condition, specifically looking at removing cells that make antibodies, which are B cells. Now, as some of you who are immunology trained recognize, antibodies are actually made by plasma cells, so fully mature B cells. And the anti-CD19 and anti-CD20 therapeutic family are upstream of that. But ultimately, when you remove the upstream B cell population, you eventually reduce those that are making MOG antibodies because they don't mature into plasma cells. We can also block products that activated immune cells make, like interleukin-6, and that is what led to the use of tocilizumab and satralizumab, which we will maybe touch on the next slide. Before we do, I just want to touch on what do you do with respect to managing the first attack. And the majority of people that present with optic neuritis, myelitis, ADEM, the first line of therapy is intravenous corticosteroids. For pediatric patients, it's typically 30 to 50 milligrams per kilogram per day, up to 1 gram for typically 3 to 5 days for acute relapse management. Sometimes we add immune globulin for patients that have responded partially but not completely. And this is not on this slide. And then sometimes we will use plasma exchange for life-threatening relapses. For life-threatening cerebral edema in patients with MOGAD, which is a relatively rare presentation, using an interleukin-6 blocker such as tocilizumab can be life-saving. But then the debate is how much steroid to use. This is an active debate internationally. This is an Australian group, and then another group from the UK looking at how long to use prednisone and what the impact that has on early relapses. And what these data effectively say is that you are less likely to have a second event in the first year after your presentation if you are maintained on prednisone for between 5 weeks and 12 months. So that's a huge range. And there's a lot of debate on the both duration of steroids and the dose. I'm sure all of you appreciate that steroids have many side effects. And so to use steroids for months has a significant effect on the patient's blood pressure, blood sugar, skin, body habitus, appetite, sleep, emotional health. So it's not benign at all. And so the Australian study looked at trying to get down to the lowest daily dose of prednisone while still showing efficacy, and basically landed at 12.5 milligrams of prednisone for most of their teenagers and adults. And I think it was 0.25 milligrams per kilogram of prednisone for younger children. They did not have very many younger children in this study. Another approach for people that are having relapsing disease is to use immune globulin. I think that's on the next slide. Oh, no, sorry, this is tocilizumab. So just briefly on the tocilizumab ongoing work. So as I mentioned, one of the findings in patients with MOGAD is increased interleukin-6, which is present particularly in spinal fluid. It's not very reliable in serum, which then led to the use of interleukin-6 receptor blockers like tocilizumab. And there are multiple ongoing studies, and one that we may touch on shortly that just resulted, I guess a month ago, Haiwen, that maybe I'll ask Dr. Chen to comment on because she was one of the investigators in that study, that do show that patients receiving tocilizumab are less likely to have relapses. These are all patients on this graph that had at least 2 events. So a first attack and then a second, thereby declaring themselves as having relapsing disease. Next slide. And there's a lot of active work in this field. So there are studies looking at a variety of agents in MOGAD. I won't go through all of them for the sake of time, but basically looking at those that, for patients that have relapsing disease, what type of treatment should we consider? The current overall most common therapy for relapsing MOGAD in children is monthly immune globulin. Typically dosed at 1 gram per kilogram infusion at a single day per month. There's some variations in protocols, obviously a variation a little bit in, depending on the size of the child and the duration of the infusion. And there's some emerging work looking at subcutaneous weekly immune globulin, certainly in adults, and maybe emerging as a strategy for some pediatric patients. Although I think tolerability remains to be determined because that's subcutaneous needles, usually several of them, every single week, which is not typically all that popular with pediatric patients. For very young children with MOGAD who have relapsing disease, the protocol for all patients with IVIG, by the way, is typically monthly therapeutics for 2 years, assuming that they're doing well, and then a reappraisal as to whether it's time to stop the immune globulin. There's no magical way to know if that's correct. It's the current international protocol, but we all acknowledge that it's not a protocol that has been subject to a clinical trial. That being said, if you're going to keep a younger child on immune globulin for that extended period of time, many younger children have difficult venous access, poor tolerability of having multiple needle sticks. And so in some patients, I have used, put in a portacath early so that they would have safe and secure intravenous access for their monthly therapy. Something to consider in the appropriate patient. Next slide. So to conclude about MOGAD, challenges are that we don't know who's going to relapse. We don't always see all the changes on the first MRI. So sometimes if you have a patient who comes in with new onset seizures and focal findings, the MRI might not show anything on day 1, and it's only a week or 2 later that the MRI changes really catch up to the clinical feature. So always repeat the MRI if you have a suspicion. Think about MOGAD in patients with new onset, difficult to control seizures, often focal. Patients with MOGAD typically recover well from the attacks, but not always, which is why once they've declared themselves as having relapsing disease, we definitely want to suppress relapses. But quite remarkably on imaging, many of the lesions in MOGAD will resolve, which is rarely seen in multiple sclerosis. And we don't know, ultimately, even in patients with relapsing MOGAD, whether this is truly a lifetime disease, which we know multiple sclerosis is, or whether it's really a transiently multiphasic disorder. Next slide. Haiwen, do you want to conclude?
Sure. So in conclusion, we've kind of talked about pediatric onset MS and MOGAD and how they can share a lot of common clinical features. Pediatric onset MS however, is typically more a chronic and relapsing disease, whereas MOGAD can be more monophasic and also be more self-limited, but can also sometimes be relapsing as well. MS patients can develop focal tissue injury, those black holes, diffuse white matter loss, and accrue clinically silent new lesions. And on the other hand, MOGAD lesions tend to resolve, and we generally do not see clinically silent new lesions. We've mentioned that there are more use of other diagnostic tools with MS, things like oligoclonal bands, which have been more historically considered, as well as kappa light chains that are hallmarks of MS, but infrequent in MOGAD, though potentially could signal risk for relapse. And then on the other hand, use of serum MOG IgG antibody testing is quite critical for the diagnosis of MOGAD, though the titers and persistence of the antibody should not guide long-term maintenance or management. And so with that,
Oh, yes, just putting this up here. So this is an international study that we are part of, being led through our colleagues in Australia and the UK, looking at gathering a worldwide perspective on how clinicians are sending tests for MOG or aquaportin 4, how readily accessible it is. And really, it's a very short survey, but it's going to give us I think really a worldwide view of the availability and the types of assays that people have access to, which will help us as a global community advocate ultimately for standardized testing and access for people no matter where they are living. So if you have time to fill that out, we'd be grateful. We do care about everybody's opinion on the testing available in your community. All right. And now we're happy to hear from any of you. Please feel free to either put a question in the chat, or I think you can unmute so that we can hear from you. Great. So, so the question is, in resource-limited countries, can a white blood cell count differential help in differentiating MS and MOGAD? So serum white blood cell count, no. Usually they're normal, and if they're elevated at all, it's only because, at least in MOGAD, some patients have a close proximity of a recent viral infection or non-specific illness prior to their initial MOGAD attack. No virus has been specifically causally linked to MOGAD. In the CSF cell count in MS is typically normal, or if it is elevated, it's low, not a very high white count. MOGAD is quite variable. Some people with MOGAD, especially those with an encephalitic type presentation, can have a high CSF cell count, but it should be lymphocytic predominant. If it is, looking like an infectious, if it's neutrophilic, you should of course be looking for infection. You should be considering infection in anybody with a very high CSF cell count and making sure that infection is excluded. Haiwen, did you want to add any comments to that?
No, I would just say that when only add that in addition, even because we do commonly see infections associated with MOGAD, when we have very high suspicion for MOGAD, even in the setting of infection, we still actually often go ahead and treat with steroids, because oftentimes the benefit will outweigh any risk of the steroids themselves.
Correct. Other questions?
Would you recommend IVIG monthly for 2 years and tocilizumab for a child that relapses despite monthly IVIG and rituximab?
Go ahead.
So, oh, sorry, go ahead.
No, you go ahead and then I'll add.
Okay. So, I mean, I think that the question kind of depends on what we're treating here. So if the question is pertaining to MOGAD, and they are relapsing despite monthly IVIG and rituximab. I think the first things I consider are making sure that we have an accurate diagnosis and revisiting also what the monthly dose of IVIG is. So, IVIG we can use for immunodeficiencies at a much lower dose than what we use for treating neuroimmune disease. So IVIG, we typically, for these MOGAD cases, will use 1 gram per kilo, which is much higher than just replacing immunoglobulins. And usually, actually, at those doses, risk of relapse in MOGAD is actually fairly low. And especially with the addition of rituximab, actually, I would be very surprised if they were relapsing and thus kind of reevaluate that situation.
Yeah, I think so. All of that I agree with 100%. So always when you have a non-responder, revisit. Make sure you're treating effectively, double check your diagnosis, go back to the beginning. And then also look, when you're looking at, is this really MOGAD? If the lesions present at the beginning did not largely resolve, if there is silent new lesion formation, those are atypical features of MOGAD. So that would be a big flag to say, is this really the right diagnosis? Assuming that it is, and you have a patient who has had good, effective dosing of IVIG and depleted with rituximab, so you confirmed that they did actually have B cell depletion with the dose that was given, then tocilizumab would be a reasonable thing to consider, keeping in mind that all of us are just about to see the meteoroid study that will tell us a lot more about the tocilizumab or it's a treolizumab, right? Yeah,
Yes,
in
satralizumab.
in MOGAD, inclusive of safety, which I would just want to remind everybody that we're just about to get decent safety data on chronic exposure to IL-6 receptor blockade in this population, and we should all look at that as we think about therapeutic options.
Yeah, and that trial actually did include age 12 and above, so some pediatric patients as well. So that's nice.
Yeah. Are there diet habits that reduce the risk for MOGAD, i.e. foods that reduce inflammation? So great question. So at the big picture level, we do think there's a link between the gut microbiome, which itself is highly influenced by nutrition, and overall inflammatory disorders, including diseases that affect the central nervous system. But we are very much in our infancy in understanding that relationship. In terms of foods that are anti-inflammatory, that's a controversial topic because it really depends on what you're defining the inflammatory contribution of any particular nutrient to. So in somebody in the arguably simplest example would be somebody that has true gluten-sensitive enteropathy, where that particular nutrient clearly incites a rigorous inflammatory response, both in the gut and often symptomatically beyond the gut. Beyond that really clear relationship, inflammatory foods are more controversial and harder to prove. I would flip it the other way around at this moment, which is the only evidence-supported nutrient that might reduce the likelihood of attacks in any of the neuroimmune conditions is vitamin D. And even that, it's a stronger relationship between low vitamin D levels, as Haiwen showed in the slides, having vitamin D insufficiency or very low levels, and the likelihood of having multiple sclerosis. And this has not been very well studied yet in MOGAD, but studies that have tried to give high dose vitamin D as a therapy have really not been able to show that this reduces relapsing disease once the disease has started. So, I mean, the overall has been not strong evidence for that. So most of us as practitioners would believe that having low vitamin D is not good for you and particularly not good for you when you have an active autoimmune disease. So we tend to use vitamin D supplementation to try to bring people up into the higher end of the therapeutic range. But mega dose vitamin D, I don't recommend. And the studies that have tried to do that have yet to show a major impact on clinical disease activity.
In pediatric MS is a large number of lesions with no clinical symptoms correlated with greater disability progression eventually. So That's a challenging question because in pediatric MS, what we'll often see is that patients can have very active disease early on in their diagnosis. However, meaning that they could have a lot of lesions, but kids in general tend to recover better. So even when they have very active diseases, a disease process, they often can recover to having minimal disability. However, what we do see is that that does catch up with them long term, that if we were to say leave them untreated for years, that they do develop disability down the road. It may take them a longer time compared to adult onset MS comparisons, but they actually develop a similar degree of disability, often at a younger age, in part because they've been experienced in the disease process longer. So it's not necessarily a clear correlation between just like the lack of clinical symptoms and eventual disease progression.
All right, so the question next is, how do you feel about an MS diagnosis without fully meeting the 2024 criteria? So in actual fact, the 2024 criteria provides so many avenues to confirm a diagnosis of MS at onset that making the diagnosis in someone who doesn't have the 2024 set of criteria would really worry me. And so, obviously the devil here would be in the exact details. And there I would say, I try to think of a scenario where that would apply. So if someone does not meet the 2024 criteria at the time of their first incident attack, so let's say they have optic neuritis, so they have one topography, they have one or two non-specific white matter changes that don't hit any of the other topographical locations. They don't have a central vein sign. They either didn't have spinal fluid testing, or very uncommonly were oligoclonal band negative. You would not be able to confirm the diagnosis of MS at that time. So there, what you really need to do is watch, serially image, and closely evaluate. We always get pushed right now into the importance of prompt diagnosis, rightfully so. Early therapy, we didn't have a chance to show slides on this, but highly effective therapies given early in relapsing remitting disease in children and adults mitigates, as Dr. Chen was just saying, the risk of disability progression. However, if you don't have enough evidence for the diagnosis on day one, this is a lifetime diagnosis to make. I would follow them with 3 monthly imaging. I would keep a close exam on them, and I would wait to confirm their diagnosis. Because if they don't meet criteria, there's a high chance they have something else. And I'd be very vigilant about looking for other causes of white matter changes in the MRI, if that's what you're seeing, or other clinical phenotypes that might start with a similar story. Hope that answered your question. Oh, right. And I apologize, but we do actually are going to have to run out of time. And I am chairing another meeting right now. So I think we may have to end at this precise time. But if there are questions we didn't get to that people have put in the chat, we will, if you put how to reach you, we will, I will ask the organizers to help try to connect us so that one of the two of us can respond. And of course, we're not hard to find. So feel free to reach out to us if there are more things you'd like to talk about. Happy to chat directly. Haiwen, any comments on your end?
No, just that we're available and we would really like to assist with these patients.
Yeah, happy to help at any time. And thank you to the Hopkins organizers and to all of you for joining. I hope this has been valuable to all of you. Thank you, everybody.